spring into summer by looking younger. Call Vein Clinics of Hawaii to schedule your free consultation today. Facial and body rejuvenation procedures are designed to help you look and feel your best without breaking your budget. Reduce pigmentation, fine lines, wrinkles, scarring, and stretch marks with minimal invasiveness or side effects. Confused about which procedure is right for you? Call 427-5565 to schedule an appointment or visit veinclinicsofhawaii.com.
Aloha Hawaii! It's time for the Vein Clinics of Hawaii radio show. Their team's approach to diagnosing problems and developing solutions and treatment plans are beyond compare. So let's get started with your host of the show, Mike Buck, and Medical Director, Dr. Randall Juliff of the Vein Clinics of Hawaii.
Well, hello there and welcome to the program. Today we have a full studio. As a matter of fact, you've heard us talk in the past about the staff and the folks that are working with Doc at the Vein Clinics of Hawaii on the Big Island, Kauai, Maui, and here on Oahu. Dr. Juliff is here to talk as the medical director and also to introduce us as we can to the different players at the different branches. One of which we met the other day, and his passion was ultrasound. And I've actually had a couple of ultrasound treatments by Mike, and found it to be, once that I knew that that's what he did, I had this level of confidence going in that he's going to do the right thing. And I'm going to find out about Rebecca today, and that's going to be a similar case.
Well,
right?
hopefully,
yeah,
and I think you'll be finding the same thing.
Yeah. But is it sort of interesting, because I know that we talked in the beginning about the difficulty of any growing practice or growing business is it's all about the people. And so we get to meet some of these people. So let's, first of all, give people sort of an idea of what sort of folks work in a Venus doctor's office. Yeah,
well, we've got all sorts of people. Yeah. And you're right. I can't do it all alone. And any medical practice is like this. You have to rely on all sorts of people, and you need the right people at the right time in the right place, all that sort of stuff.
Well, remember back in the day, we talked about your general practitioner and your internal medicine guy and all that. It used to be Doc in a bag, right? He got on his horse and he rode from branch to ranch, and he had his little bag of tricks.
Yeah.
And as there evolved specialties, and there were then a lot of other opportunities, and we've used the expression PA before. Mm-hmm. And so let's what is a PA?
Well, a PA stands for physician assistant.
Okay.
And they're a practitioner, they're a provider. So
they have rules. Yeah, there's rules and regs.
Well,
right?
yeah, sure. Rules there are things that they have to kind of live up to.
Sure, absolutely.
There's a certification process. There's extensive educations and training sort of things. They don't go down the same route that physicians do, but it's a similar route. Mm-hmm. Not quite as long, but they still are learning all the ins and outs. And when a physician assistant sort of specializes in a specific niche, mm-hmm. the way Rebecca has coming on board with us, they learn a lot about, our world, our specific world.
Okay, so Rebecca, we won't talk at your back anymore. Now that you're in the room, but we never really did. But what I did is, and when Rebecca and I met at Doc's office, it was I want to say a hallway consult, right? Sure. And you were ready for that. And I was first of all, I've been totally impressed with everybody there, and so it must be, number one, not just rewarding because you're doing what you want to do, but it must be, I don't want to say fun, but an office that you look forward to going to instead of dread.
Oh, absolutely.
What got you here? First of all, how did you become a PA?
Well, let's see. My husband was Coast Guard.
Mm-hmm.
We moved around a lot. Had a couple of children that I was taking care
mm-hmm.
of. Got back into school.
Yeah.
Got my bachelor's. Got my master's in PA. I chose that because I saw the writing on the wall that I wanted to get into surgery.
Great.
I love the aspect and the thought of being an assistant to
There's
surgeon.
all kinds of surgeons, right?
Mm-hmm.
All kinds of surgery. What was the first surgery you were interested in? Was it vein surgery right off the bat, or were you orthopedic surgery? What did you like?
General surgery.
General surgery.
Mm-hmm.
Yeah.
General surgery.
Like I just cut myself open and I need to get
Yeah, appendix. I could take your appendix out right now.
Yeah. That's comforting, you know. If
So
I get a southern pain, doc, I'll let her know, and she can go ahead and do it.
Yeah,
you know?
sure.
Yeah,
We'll certainly diagnose you and send you on your way.
Yeah, and isn't that sort of the deal on a regular basis? You know, I don't want to say if you get to do the things you like, but it must be there's a tremendous myriad of work that you must do every day in that office.
It's varied.
Mm-hmm.
It's excellent, and having the varied situation of different patients, different situations, different pain, vein issues, and varying issues with the patients themselves, and being able to bring some kind of fruition to that or promise.
Sure. Yeah, I think that's kind of cool, Doc. I mean, you know, everybody, and I'm not sure if anybody that's sitting in the room with us is not a little bit intimidated with the boss sitting right next to her. You know, that's part of the stress.
Really?
Stress level.
Gee, that's a surprise.
So
to me.
far, but seriously, I think that if we give one little examples, is you must have perceived the need. Then how do you go out? How do you go about finding somebody that fits that need?
Yeah. Well, you know, about the same as for any other position in the office. But if a person has an interest, I think that's the crux of it. The most important thing is an interest in what we're doing. You know, for instance, as a physician assistant, and you touched on this before, physician assistants education is a little greater spectrum, a little wider variety of things, different types of medicine that they may be educated in and equipped to do. Whereas when you're going down a tract within, being a physician, most of the time you're going to specialize in something. And so there's a lot of different things that Rebecca is bringing to our practice from not only her education, but also her other experiences. And I think that was one of the things when I first met Rebecca. One of the things that impressed me was that she had a pretty wide variety of experiences, and you learn from all of those.
Well, you know what? I think anybody that's been a regular listener of our program heard in the very beginning that you didn't start off as a venous surgeon.
No.
You started off as a heart surgeon.
Right.
I mean, that's like the main thing,
Yeah.
And yet when you made the transition, what were some of were there people that, for instance, were surprised because you were a heart surgeon and now you're going to do something else?
Yeah.
Yeah.
Well, I hear that all the time.
I bet classmates and other friends and stuff.
Yeah.
I don't want to say surprised, but really, what makes anybody change? And by the way, isn't it sort of tough for some people to change?
Well, it is.
You get into a mold, and there you are.
Especially surgeons.
Yeah.
They don't change very easily. Yeah. But I think the people who are the most surprised about that transition, the transition that I went from doing heart surgery in the hospital most of the time and being in that whole environment to what's going on in the vein world these days. They don't understand what's going on in the vein world these days because it really is kind of an exciting time. I mean, we're treating patients in a way that we've never been able to treat them before, and really changing lives, really impacting the quality of life of the people that we are treating.
Yeah, that's pretty interesting, Rebecca. And I guess because I saw you nodding, I really can appreciate maybe somebody working in an office realizing that the doctor is investing into the future with technology and he's not trying to live one way and do the old stuff. So here's a guy that must be reaching out to people like you and saying, here's the things that we can do. Here's how I'm going to make your job to stay on the cutting edge. Excuse the expression, but that's kind of what it is, isn't it?
It's always exciting to stay on top of the newest modalities of medicine and such. And when I was in primary care, for instance, I had a number of patients that came in with venous ulcers. Yeah. And the only direction I had to go in was to a venous surgeon, a vascular surgeon. But they sent them back to me and were in stockings only. We really didn't have a modality to fix the problem, and it was frustrating. So when I met the doc and the vein clinic and such, and I was very excited for what we can do at this point in time. And it's been the last 15 years of advancement in this area of medicine. It's very exciting.
When people get to that stage where they have venous ulcers, that's kind of scary, right? They're pretty involved in a venous condition.
Well, it's been a long-term condition.
Yeah.
And you know, when you're seeing the tissue then break down, you definitely want to be able to do something dynamic and progressive. And what we've had to use in the past, which would be, Una boots and stockings and such. And when we get them over the healing portion, we've been able to do that in the vein clinic, which has been really exciting for me and learning, because I did some wound care over at Tripler for a number of a couple of years. And again, we saw a lot of venous issues, and it was always about the Una boots and not so much the intervention that we're doing here with
Doc,
clinics.
we got to give her my file, right? Because she's talking my language here.
Yeah.
With a major ulcer and hearing all those things. And I guess once you hear it from enough professionals, you think, okay, I got to do this. Boy, that's an ugly thing, but I guess I got to do it. But what I'm saying is that, and I've been, ever since we started doing this show, I've become so much more aware of people. Like I was in a big box store the other day at a customer service desk, and there was somebody in front of me. There was, morbidly obese in size, and his one leg was wrapped in white, Doc, like we've talked about. The other one was black.
Yeah.
And it had this huge bandage on it. And I thought, there's an ulcer behind this guy.
Right, right.
And he couldn't even stand up. I mean,
sure. Yeah. I see those people all the time,
sure.
And I want to start handing out business cards, but I always restrain myself.
That's kind of tough, isn't it? Because I'm the same way, and you almost want to say if you see somebody doing something wrong, you say, if you'd only turn that thing on, it's got a motor in it, but you just don't do that because maybe people are in denial, or maybe in your case, Rebecca, you can point out where maybe somebody went to treating a wound for a long time by putting this antibiotic and a Band-Aid on it, and 6 months later the thing's not healed and they don't know why.
Exactly.
Yeah.
And some of the local practitioners don't know where to turn, just like I didn't when I was in primary care. And so to be able to get the word out and help people understand that this is a modality that can actually turn the corner and really give them some answers to the problems that they've been having with their legs, it's very exciting. I got to tell you, Doc, since we talked about that before, I had doing one of our homeless programs that I do, I had Dr. Josh Green in talking about the outreach that they're doing in the homeless community for people that have open wounds. And the most common one was, of course, venous leg ulcers.
Right. Well, not only that population, but the general population of people that have ulceration in the lower extremity for one reason or another. 65 to 70% of those people are having that because of vein issues and easily fixed and easily treated. But before we talk more about the clinical stuff, I think it would be interesting to hear Rebecca let us know what she did from an educational standpoint.
Yeah, that's what I really want to get into.
Because there might be people out there who are listening and saying, "Gee, what do I have to do to become a physician assistant?" That sounds pretty interesting. So why don't you go through each step, Rebecca?
Sure, I'd love to. So when I was able to get back into school, I got my bachelor's and finished that up, and found a master's program in physician assistant.
What was your bachelor's degree in?
It was in pre-med. I knew I wanted to get into medicine. I just didn't know how I was going to be able to get into medicine.
In this day and age, isn't it nice to know that there are lots and lots of categories?
Oh,
that
absolutely.
You can really zone in on something that is meaningful or that is connecting with you.
Yeah. Well, originally we were in Florida, and I thought I was actually on the process of going into physical therapy. I was going to be a physical therapy assistant, but my husband was then transferred, so I had to do a full-on backup and restructure and refocus. And that's when I met my first PA. He was actually my practitioner. I was so enamored with his love for medicine and his job, and I said, "But you're a physician assistant. You're not a doctor." He says, "I love being a physician assistant." And I interviewed him, and he explained to me what it was about the position that he loved so much, about helping families and being able to travel and do those things. But at the same time, it was an up and coming, more dynamic area of medicine that was available. So I looked into that and found that in Virginia they had a master's degree opening up, and I made my goals and I set my goals.
Good for you. That's great.
Now, are all PA training programs, all of them are not master's degrees? Is that true?
Historically, they were certifications only, and
Oh,
then
I
they
see.
went into bachelor's, and then from the bachelor's they've rolled into masters. And there are some people who have had their double bachelor's to get into the masters, but at this point in time, with the expansion of the profession itself, then the master's degree is where you want to focus.
Yeah, it sounds to me like it is an area that has real growth potential, particularly for people like yourself that, for whatever the reason, didn't continue with education as, pre-mom days, and all of a sudden later on said, hey, look, this is a great... So you took a leap of faith into doing what you're doing, but then you have this choosing. So what I'd like to know is what eventually got you around to choosing the Venus area?
Well, we came out to Hawaii. It was our last station in the Coast Guard.
Yeah.
And previous to that, I was in ER medicine.
Oh, okay.
And minor surgery. I was in the fast track. So somewhat of the minor area in the ER. And I loved the procedure aspect. And when we got out to Hawaii, I took a position with Tripler in the general surgery and in the minor surgery arena as well, and had some excellent training. And after about 3 or so years, and in wound care as well, when I saw the open invitation from Dr. Juliff to come on board and be trained in a specific area as the vein arena, then I knocked on his door and
Doc, it's sort of deja vu all over again for, I guess, each person you find, and miraculously sometimes the right people come along at the right time, which gives you a chance to increase the staff to the level that you need.
Right.
So I'm guessing you're keeping Rebecca pretty busy.
We're trying.
Yeah.
We're trying.
Not too many slack days.
No. And that's the way that you grow. I mean, if you have a practice and you want to grow that practice, it's absolutely imperative to bring people in who are on the same page, have the same interest, and allow for that growth to occur. When we find good people, we bring them in. Sometimes, and it takes a little while for them to learn the process, but invariably it always results in us being able to treat more patients, which is what we want to do.
Which is what you want to do. And by the way, gang, some of this stuff we are not able to show you on the radio. When I mentioned a while ago about venous ulcers, which we're going to come back on, I promise. There's some pretty dramatic video available if you've seen Doc's TV commercials. And if you go to the website, veinclinicsofhawaii.com, veinclinicsofhawaii.com, you can see why sometimes, and Rebecca, this is sort of interesting because you deal with everything from somebody with just strictly a cosmetic, thing they want to do on their little spider veins so they can go to the beach and look at my legs.
Right.
And wow, this is a real challenge.
Right. And one of the joys of working with this modality is being able to educate people about their legs.
Sure.
Because if they have the spider veins and such and something is showing, they really don't know what's going on underneath or could be going on. And so we do the investigative ultrasound, which really gives us a full understanding of the activity of the venous arena.
Okay, wait 1 second, because I think this is really neat. In that instance, are you sometimes able to really make people get a sense of relief, saying, okay, I was here for the cosmetic, but I wanted to know this, and inside I'm pretty good. I mean, it doesn't mean that you have a bunch of little spider veins. It doesn't mean necessarily that you have worse disease underneath.
Well, of course. Yeah. It really depends on what's going on. And even when we do see some evidence, it doesn't mean that they necessarily have to go for the procedures.
Sure.
And we talk about that. It really depends on where they're at, how their symptoms are. And so we have that discussion.
I think, Doc, it's kind of interesting because I'm sure that this happens in your waiting room. When people are being processed, when they're sitting next to somebody and they say, well, what are you here for? And the guy says, I'm here for a sore that I've had for 2 years on my leg.
Yeah.
And she said, well, I just want to make this leg look a little nicer. So there's degrees of why people walk in.
Oh, yeah. Yeah, it's a pretty wide spectrum of patients, and I think that makes it even a little more enjoyable. I mean, we love treating our cosmetic patients as much as anybody, but, the people that we really get, satisfaction from treating and making their lives better are those people that have the higher levels of vein disease, especially those people that come in with ulcers.
Rebecca, I've talked till I was blue in the face with Doc in the past, and knowing that the disease or condition is hereditary in many cases, and knowing that my mom, who was on her feet as a model and a store owner for years, had massive vein work done. And I'm guessing that sometimes now, when you see a patient, they're relying on the experience that either they or a parent or grandparent had. And you must be able to relieve a lot of people by saying, you're not going to the hospital for 3 days here. We're going to have you out of here. You're going to come in, you're going to get treated, and you're going to go home.
Oh, yeah.
Yeah.
I mean, that is a great turnaround when you see the face and they're like, oh, well, that's all this is.
Yeah.
That's what I can do.
Slap, slap, fizz, oh, what a relief it is, right?
Right.
Yeah. And I would imagine that happens kind of frequently, that people are reluctant to come in because they know of somebody else in the family that a generation ago didn't have a real good time getting veins worked on.
I hear that a lot.
Yeah.
And again, one of the aspects that I really do get a lot out of my encounters with patients is the education of, and sharing with them what's going on, what historically was available historically, and what we can do today. And that's a real joy. Yeah,
well, one of the things that comes up, Doc, and maybe you can explain how you and your staff deal with this, is that to get somebody to be proactive is important, but you got to give them like incentives. If you do this condition is going to be better, i.e. elevating or compression stockings or whatever. But there's no just, here's a bunch of pills, you're going to be okay. Take one of these a day.
There's no magic pill, unfortunately, and a lot of people come in wanting that.
Oh, of course. Where's my pills?
And that all kind of goes to the educational process that we have to do. Instructing them with respect to what is really going on. I mean, I think a lot of people come in and they have kind of a minimalistic view of, the whole vein problem. A lot of people think they're going to come in, they're going to show up, we're going to do a few little injections, and boom, everything's going to be fine.
In an ideal world, maybe some of that's true.
And very occasionally it is true, but for most people it's not. But education is a big thing. And I was just going to mention before, we do as much outreach kind of things as we possibly can. We go to groups and talk to them, or we go to health fairs and try to, do vein screenings and really try to educate the people, the population, because so often, as we've talked about before, they have venous disease. They're having symptoms from it, but they don't know it's due to a vein problem.
But, we've talked before, Rebecca, about being proactive. And I know that a lot of people say, well, can I change my diet? I mean, what should I eat to prevent, getting this kind of thing? And I'm sure there's some things that people can do if they're obese, and Doc and I are going to do a whole program on that in the next couple weeks, where it's one of the real big problems is obesity. And I know you see that as well, a lot.
Well, absolutely. I mean, there is a certain area of the population that comes in, and that's one of their issues. And oftentimes we'll talk about, their history, what they're doing currently, what kind of medications they're on. And sometimes we'll talk about specific issues, specific medications, and then I might give them a little bit of my own educated knowledge behind that and encourage them to go back and be a little bit more proactive than they are currently.
Sure.
If it comes, if that comes to the surface.
I'm worried, and we talk about this a lot, that a lot of people use Google as their main consultant, and they sort of self-diagnose. And I'm guessing sometimes when the people come in, and I've seen you in the office when you're working with somebody that's brand new, their first time in there, they come in with a bunch of misapprehensions and probably a lot of sort of half-truths or no truths.
Well, some people come in and they don't want to hear what you have to offer.
Yeah. Well, wait a minute. I actually, we talked about this on a previous show. I loved the last time I went there, I got the iPad. And I had to fill in. I had to do my homework. I had to do this thing. Yeah. And I'm guessing that you're the one getting the iPad.
We get the results of the iPad, and then we talk again.
That's what I'm talking about.
Everything that has been shared on the iPad, and we expand on that. And we go in a little bit more detail because we're also creating a story and an understanding of your history and what's going on with you currently and prior to.
The reason I brought that up is because it's just another one of the advances that it seems that the doc is willing to get going. Because it's not like on a scale of 1 to 5, what are your pain to you? And today it's like, holy smokes, I got to write a book. However, but I got good marks. You told me that I filled mine out pretty well.
Yeah, you did. I did a good job. Now, I do want to point out to most people many people that probably having your reading glasses handy.
Oh yeah, that would have been nice. I was in a full squint the day I was there. Well, I didn't expect I was going to write my life history down. But that's another thing. I think that let's talk about maybe some of the things that you would instruct me to look for while trying to help me get diagnosed with what's wrong with me or what my fix is going to be. What's the difference between tingling and itching and throbbing and aching? Well, I guess they could all be the same thing. It depends on who the guy describing it is, right? Like me.
Very true.
Yeah.
And so you would ask things like, does it sting? Does it burn when you're laying down, when you're in bed? Do your legs continue to twitch? Do they wake you up at night? Are you in a full-on spasm or cramp? What have you done for that? Have you taken any medications? Are you on any vitamins? Have you tried any additional magnesium?
Doc, it's really apparent that one of the biggest things that you need to differentiate in a person is what specialist should this person be seeing? And its case in point was, Rebecca, you love this because I know you've seen this, is one lady had been going to a dermatologist for a long time on a skin condition. And the dermatologist was the one, I think, that said, you know what, I don't think I can help you with this. I think you need to see a venous guy. And talk about how when that person comes, you're predisposed. You're going to be able to help that person a little quicker. If you've eliminated the fact that person was at a dermatologist for 6 months with this cream and that cream, and the thing's still there.
That's very true, especially in the area of eczema on the lower legs, and they don't have eczema in any other aspects, their knees or elbows or in their hair, and the other areas that you might see it and you would expect it, but it's just on their legs, and so it's easier to point out that this is a condition that is caused by the swelling and the enzymes and the proteins that are distributed by the veins when they're under pressure and irritate the skin and can produce that. So that education, again, for the patient is so important for people to be able to be in partnership in, coming to fruition and finding them an answer to their issues.
What about when you sit down with somebody after the initial diagnosis, if you will, or talk, and then the iPad history and all of that kind of stuff? Doesn't that then give you a pretty good idea to present to somebody that this is what you are going through? This is the label we're going to put on what you've got. And now, so the first thing I'm going to say, well, what are you going to do to fix it? Then what do you tell me? How do we discuss different programs that may be available or that I should follow?
Right. So I try to come at it towards it in an aspect of looking at the whole person and seeing where what issues that they're having currently, what kind of medications they're taking. It gives me more of a global idea of what's going on, and not just their veins specifically. We talk a little bit about it. We don't get into depth, but I believe that they feel a little bit more confident in that we're not just giving them an answer because we want to do something with their legs, that they're actually seeing that we are interested in their overall condition, including their heart. And their,
that's why I'm impressed. I mean, ever since I met Dr. Juleff, I'm going through some stuff right now that he's been able to steer me and help. And then when you go to, if you have to go to, say, a heart guy or this or that guy, you think, okay, I got a team approach here, but I am concerned about one thing, and I'm sure, Rebecca, that you get asked this question a lot. And Doc, maybe it is, I think right now people are branching out and reaching out on so many different medicines because they're so prevalent in advertising and promotion. People think, well, I want that because look at that guy's good. And he doesn't realize the 30 seconds of horror stories that they're telling you at the end of the commercial. Are people over-medicating sometimes and trying to look for pills instead of looking for treatment.
Well, I think a lot of people do that, but a lot of that is a result of the media that they're exposed to every day. Because it seems like every time you turn on the TV, there's some medication that they're trying to sell that can do this or that, and in your mind you're going, well, that's not going to accomplish what you need to have accomplished. But I think the American people have kind of grasped onto that because, again, it's sort of a quick fix.
That's what we want, the instant gratification, right?
Yeah, sure. And, you don't have to go through the multiple steps. Theoretically, you don't have to go through the multiple steps that we really need to go through to figure out exactly what's going on. So sometimes we have to kind of reroute people from thinking of that. And one of the first things, Rebecca, that comes to mind for me is that, when you have, let's say that somebody comes in strictly for cosmetic treatment. They got spider veins on their legs. It's a gal that she wants to go out and play tennis again, wants to go back to the beach. And she thinks, okay, how soon are these going to go away? I had an experience when I had this horrifically big thing, it was like a big spider web on my leg. It'd been there for years.
Right.
And it looked really awful, worse for a while. And now it's gone. I can't find any trace of it. Do you have to walk people through the patience level on that?
Absolutely. Absolutely. You need to curb the enthusiasm with the treatment of spider veins and give them a full understanding of what they will be, what the result is. I went through it myself. I had some injections done over a tripler, and they told me they were going to get a little bit darker before they got better, and they were behind the back of my knee, so I never looked at it, but I had a relative that was just aghast and very worried about me for about 5 seconds or so, and I said, oh, no, that's just my legs. That's just my injections. It'll go away.
Yeah, but Doc, I know that comes up a lot. And we men are less likely because who looks at the back of our legs? Nobody, right? No. And nobody says to dad, hey, you got that big thing. But if mom's got one, hey, that's not going to be there for very long. It's going to get treated.
Oh, yeah.
Why is it, by the way, and I guess I'm just as curious as anybody else, Rebecca, as to where most of the venous appearances come up? I know most of them are below the waist. And most of them are below the knee. But it's not uncommon, is it, to have some in other places? Like around the stomach or around the, higher up the back, the buttocks, all that stuff.
In those areas specifically, there may be more of a congestion in the venous and arterial areas that would need more investigation, perhaps by MRI and CT scan and more in depth than we go through at our clinic. Yeah. If we start seeing those things, then we certainly would direct the patient in the right area and get those tests taken care of. Of course, talking with Dr. Jula first because he is the expert, whereas I don't necessarily have that expertise, but that's why he's the medical director, and I would have them set up an appointment with him specifically so that we would get them
That must, Doc, in many respects, be where you make the decision of passing the baton in certain areas to certain other people in the office to do things that is up their, up their comfort zone, and which makes it possible for somebody to get a well-rounded treatment and get what they need and not have more than they need, just have what they need.
Yeah. Well, I think getting back to your question, spider veins happen for the most part on our legs, but, superficial dilated veins can happen anywhere on our body, quite frankly. And, sometimes, like Rebecca just alluded to, sometimes it's a sign of some other more serious problem, within the vascular system, and we have to kind of sort that out and decide, like she mentioned, does this person need further evaluation to make sure that they don't have anything really serious going on, and we've run into that occasionally. On the other hand, we if somebody has spider veins that they don't like the looks of, and it's not connected with a medical problem that needs other attention, we're happy to treat them.
Yeah, and by the way, what comes to mind, the Irish side of me says, I remember old Uncle Mick, because he had them all over his face. And, I guess that's a theory of a badge of accomplishment or something. But it seems to be that. Are there certain ethnicities that have that as a condition? And I think what we're talking about here is the guys that have the busted veins from drinking.
Yeah, well,
Is
it
from drinking, or what is it from?
Yeah, well, some of it might be, but some of it is just genetics, and a lot of that has to do with skin quality. Some people, you can see their veins much easier, and some people just have the propensity to develop. We treat a fair amount of facial spider veins.
Are they treatable in Rebecca, kind of the same fashion?
They
inject them, sclerotherapy, whatever you call it.
Yes, they are. They are absolutely injectable.
Yeah,
and we do other things too. Facial spider veins. We can also use the laser on. Occasionally, we do that. It depends a little bit on the quality of the vein, but a lot of people don't like the look of the veins in their hands and arms. And again, if we've made sure that
I've subconsciously, as you noticed, looked down at mine
I noticed that. Yeah. So we can take care of those if you want us to.
Yeah.
But
we have a solution for that.
Yeah.
We treat that, and a lot of women don't like the veins that are a little more obvious on their shoulders
and around the neck and chest, upper breast, and all that stuff too.
Absolutely,
right?
Absolutely.
And that part of it, I get it. I mean, everybody's really vain. We don't want to admit that we're vain. Guys are just as bad, but women seems to have more confidence getting treatment based on how many people they know that went through that and had treatment and came out looking as they wanted to and not having a downside to it. You know what I mean?
I don't really look at it as a sign of vanity as much as of wanting to look and feel healthy.
Yeah.
Look as healthy as you feel, or feel as healthy as you look.
I don't either. I maybe shouldn't have said vanity. I meant more, self-confidence and stuff to say.
Absolutely.
I'm not worried about that. I am who I am. Here's what I am. Right.
Right. But there can be some aspects of your facial features or something that could be discussed, and if you've got something like rosacea, which can absolutely be discussed with, in dermatological terms, and for lasers and lotions and such, other spider veins. There's a whole gambit of skin issues that can be addressed.
That being said, let's talk about how you have to walk through the situation with people that need to know what their diagnosis is and what insurance was going to cover. At what point in time does this become a cosmetic decision, or is this a medical decision? And how do you find that out? And how do patients take it once they find out, hey, you know what, this is really just cosmetic?
Well, there are some things. There's some plans that you can put together that can incorporate the insurance companies. You, of course, work with their guidelines, and having and some knowledge and a really good front desk assistance that can help you with that is so important. They do their job very well, the ladies that work with us, and they can really school me on those aspects of payment or non-payment and which direction we're going in. But the history is so important, the plan, and thereby the plan, and then the fruition and how we get to the end point. And
I'm really glad. I'm glad to hear you say that. And Doc, we've talked about this a little bit before. But here's another thing. I don't know if this comes up. We're living longer. I mean, the average person now, it's getting into the 80s and 90s is kind of common. I mean, you expect that. Mm-hmm. But there are some things that can't keep up with that. And you said before, people didn't really have a bad problem with the venous condition because they didn't live long enough to have it become a problem.
Right.
But it seems to me that this sucker comes sneaking up for about 30 years, and now it's full-blown there. And your quality of life is going to suffer if you don't get it treated.
Yeah. The symptoms, as we've talked about, symptoms come on so slowly and so over such a long period of time that I think that for a good number of those years, people find it easy to ignore those symptoms because they say, well, I'm just getting old or whatever. And until they get pretty bad, and then, or if somebody else, says to them, "Gee, why are you walking like that?" or "Why do your legs look like this?" And then sort of urge them to have it taken a look at. But it can creep up on you, and the important point there is that often it's not just I'm getting old.
Yeah,
No matter how old you are, we can make your legs feel better.
Well, that's the key. I mean, that's why. And Rebecca, you've been there now long enough so that you're seeing people come back for a reevaluation way after they've had a procedure. That must be really really great part of the day.
So rewarding.
Yeah,
it happened today.
Yeah, that's
just walking through the lobby.
What was it? What happened?
Just walking down the hall through the lobby, and one of our patients said, "Oh, my leg feels so much better."
Yeah.
And he's spreading the word. And
I know, Doc, they're like troubadours, right? You don't have to pay for your advertising this week because Charlie's out there. He's going to bring in a whole bunch of people. But I think that it is that sometimes that must also feel to you, Rebecca, really neat when somebody comes in and says, you treated Sally and Sally recommended that I come and see you. Is this kind of similar to what she had? And can we talk about what you can do for me?
We hear that all the time. Yeah, we hear that all the time. Yeah. My they would say, oh, my girlfriend or my neighbor or my sister. The gentleman I talked to today, the most rewarding aspect of our discussion today was that he was telling me that his wound that took 6 months to heal, and he's in wound care, took a week after our procedure. Yeah,
that's amazing. So it was amazing stuff.
Yeah. And there goes the whole reason why we do medicine.
Yeah, and Doc, I know that if these happen every day, all day, there would be lots and lots of people in the profession because it'd be so much fun to deal with people that are good all the time. But isn't it true that you and the practice and your people sometimes have to invest a lot of energy into a patient because the patient is at a point in their diagnosis and their treatment, they really need a lot of help.
Sure. Yeah. Everybody's very different, within the venous world. And people who have venous disease, I mean, there's such a spectrum of, how they present. There's such a spectrum of what they've gone through in the past. We see a lot of people who had, old-fashioned surgical vein stripping 20 years ago. We saw a lady like that today. And but her problem has now continued, which is very common. So we figure out what's going on right now and kind of take her through the process and give her the relief of knowing that she doesn't have to go through surgical vein stripping again. Yeah,
that's really good. And Rebecca, I guess, because Doc straightened me out a long time ago about veins and arteries and everything else, but I guess that a lot of people don't really understand. Inside that leg, there's lots of stuff going on. It's not just veins and arteries. There's it's a traffic jam sometimes, isn't it?
That's very true.
So this must be great. I mean, which procedures are the most not only challenging but more rewarding for you that you do?
Currently, I think the procedures of the just closing down the most troublesome veins and the great saphenous vein we talk about a lot. There's some aspects of the great saphenous that is the larger of the veins and is usually the player, one of the main players of the venous branches and the bulgy veins and the real swelling that they're dealing with. And so closing that down, which is, these procedures are not that difficult. I don't find it at a level of high difficulty. The procedure is, and I tell the patients all the time, we do this procedure over and over and over again. There are some aspects, everybody is different of, the risks that are involved, but we mitigate. We take steps to mitigate.
Doc, I think we've sort of touched on this a little bit before, where sometimes a dental surgeon is a root canal guy, and he just does 50 a day. That's what he does. And it's not that he's limited in what he's chosen to do that, because he knows that if he can take care of that, then the next guy's going to have a lot easier doing the job that he's got to do. How does that work in your office?
Well, I think it's very much the same. And I think, part of the reason why I was attracted to treating venous disease is because, it's a pretty small niche within vascular surgery, let's say. But we do this similar types of procedures every day of the week, and that's good because you get to learn the little tricks that make it easier for, not only us to accomplish what we need to do, but little tricks that make it easier for the patient to get through the whole process.
Yeah, that's what I was getting at. So, Rebecca, I wanted to sort of jump in your bag of tricks and see what are the things that you've not just discovered, but where do you sometimes lean? This is a perfect application for this thing. That's exactly what we're going to do for you.
Well, specifically, running into a vein that's very small and not wanting to take the catheter. And so Dr. Julev actually showed me today the use of a foam glycerin derivative that we use for closing down veins, but it was the use of the glycerin to help that catheter slide. That was so rewarding.
Yeah. It's like
because,
grease.
It was so rewarding.
Yeah.
It's like, oh, of course. That makes so much sense. But I hadn't applied it in that sense before because I had not been running into this problem. So now we run into, a small vein problem. Everybody's different. And the doctor was there to show me, it's just this little fix here. This works really well.
Doc, we talked before about sometimes obese people. And at one point in time, most people know that was my condition. It was very bad. That it gets pretty tough to just get in and do the work because there's just so much stuff between where the work needs to be done and this person. Yeah. So let's talk about how maybe in preparation for procedures and treatments, you got to work with someone and say, in an ideal world, if we could work with you on a couple of things before doing this, that's going to be easier to do. Is that true?
That is true.
Yeah.
And now I think even a little more in that vein, excuse the expression.
Yeah. I think it's a great incentive.
Yeah. Now we have had people come in that are very obese, and they come in with leg complaints, and we evaluate them, and we do an ultrasound. We find out that they have some amount of venous insufficiency. Usually, they always do. But we've turned away people from our treatment because they had higher priorities.
I want to know about that. Rebecca, when you see that, when you know that somebody would eventually be a perfect candidate for some of the things that are done at Vein Clinic, that they have maybe something a little bit more urgent or a little bit more pressing, that's a field of what you folks are comfortable doing.
Well, it's in the recognition of that's so important. Because in medicine, in your training, the first thing, especially for a PA, is to recognize what's wrong and know the direction in which to point the patient. So if it's an area of obesity, then you do the recommended, or rather the whole discussion of how far have you gone with your primary care physician in the area of your weight.
Sure.
And, what kind of conversations have you had? And what other comorbidities are they having, whether it be diabetes or any kind of
all of the above.
High blood pressure and all those things that come with it.
Things, right?
And what kind of medications they're on. And then you get into a conversation outside of vein and really focus on, and try to help the patient understand where we really are at that point.
And we do whole shows about that. We're going to do some more. But what I thought is to bring it out is that sometimes, if for instance, if you are a candidate for bariatric surgery, they want to say, okay, this is what you can look forward to. But first of all, you got to show me that you're going to play. You got to lose 30 or 40 pounds or I won't do you. I won't, just because you have to have skin in the game.
Right.
Isn't that similar?
It's very similar. Because, for instance, the couple of people that we have turned down before because they were so obese, that's sort of the step that we were going through. I mean, they had to show that they were going to do something about, these more critical issues, because us, treating their vein disease at that moment was not going to, make them a healthier person overall. And probably it would, if they didn't address these other problems, it would not make a difference in the long run anyway.
And then earlier, Rebecca, you talked about this person walking down the hall making your day. And when somebody comes back and says, you know what, I walk every day now, and I couldn't, or I had trouble doing it before. But I don't think that's what I really want listeners to feel comfortable with is to know that when they come to vein clinics, when they see you and they see everybody there, that everybody's got their part of the picture that they fit in, and that there is going to be total multiple people caring about how each patient's outcome is.
I think that's the goal every time we walk through the door.
Yeah, that's great. Yeah.
It really is, because being in a small niche, we do see a large gambit of the population that have other issues, and having that conversation and making sure that they are of the understanding of what their issues are, and that they're being addressed, and that they don't just see their doctor maybe once a year. That's important to me, that they understand, they're educated in where they're at.
Did they get the idea that they're going to need to come back, like Doc and I talk about almost every week, about compression and about elevation and about a annual, or at least every 2 years, if not every 2 years, every year, ultrasound to see what's happened since the last time we treated you for something?
Well, we're in partnership.
Yeah.
Once they come into Vein Clinics and we're working with them, I always state that, we are going to work with them through the next year.
Yeah.
That we don't just do this procedure and say, we'll see you if you have any more problems. Come back and talk to us. No,
but I was looking at it from another angle. I was looking at it from another angle, and that is that if it were my practice, I'd probably say, okay, I'm going to have Miranda, who's going to be hired just for this job, is going to go back through old patient files and say, "Hi, Bill. We noticed that your records show that you were treated by us 2 years ago. How you doing? If you're seeing another guy, good, great. But if you're not, let's not wait."
We actually have somebody who does that.
I was hoping.
Yeah, we do.
Her name's not Miranda. It's Amanda.
Yeah. Okay. Amanda.
Yeah.
I just talked to Amanda today, and you're right. She was helping me out with some appointments.
Right.
But that's what I'm talking about when it's a team.
Yes.
And then also, what is it like for you and for the whole staff, knowing that Dr. Juleff has got this plan of growth that is dependent on finding the Rebeccas of the world that want to come in and work and be a part of the program, be a part of the company?
Well, that's one of the main reasons why I came on board, because I saw his advertising, and when I was sitting waiting to talk with him about the position itself, I saw the lasers and the aesthetics that he's looking at, and the progression, and more looking towards the whole person, and so we talked about that, and that's something that I think that we're excited to walk forward with.
Yeah, and Doc, I think that some people want to do the stimuli reward. In other words, they're getting treated for a rather a serious condition, and once that gets healed, it says, "Hey, you know what? I like that picture over there. What can you do for my face? It's ugly."
Right. Sure, absolutely.
Yeah. So that's part of it, isn't it?
Yeah. But getting back to your point with respect to different staff members, you're right. I mean, it's so important to have the right people around you, and everybody, and you were touching on this before. Everybody on our team has a utterly important role to play in, bringing people in, making them feel welcome, getting them what they need, evaluating them. I mean, every step along the way. There isn't anybody in that office that we feel is a secondary sort of person.
Yeah, I tell you, I got to tell you, I observed that, Rebecca. One day, I think it was the day that I met you. There was a family in there. And one of them there for a treatment, but she had a support crew. I mean, everybody was there kind of holding her hand going through this thing.
Sure.
And so there were little kids with toys, and there's the whole thing. So it was like, okay, I'm going to get my veins treated, but it's a family deal. Everybody's got to come.
Oh, absolutely.
Yeah.
Absolutely. Yeah. No, we love to see people come in with their loved ones and support group. And we've had people come back, if they have, daughters come back with their mothers through the procedure, hold their hand. If that's a need, we fulfill it. We make that.
Yeah, I think that's really good, because everybody does know that one of the questions that you ask is, there's going to be, you're going to have to be careful about this for a little while. Have you got some help? Is there somebody can help you, or can you come in here and get us to do it? When we talked about post-surgery, there are a couple of days there where you really have to have a game plan, right?
Sure. Yeah, and dealing with the compression stockings, as you know,
oh boy,
it's not a fun thing, and we've had some of our older patients, if they're not capable of putting on and off those stockings, they come in every day, and we handle that for them.
Yeah, and we offer that all the time.
I was going to say that, but also I would imagine that every now and again a spouse or a child or a grandchild, for that matter, can you need to help grandma, or you need to help grandpa on this. You need to help him get these socks on because they're going to be good for his legs.
Yeah. we go through that, and also sometimes there's a language gap.
Yeah, of course, that's great.
I had a gentleman came in the other day, and I had a very difficult time interviewing him and explaining even just the basic process that we were going through, and I told him that he absolutely had to bring his son in. Is there anybody that speaks, that can you know, and that we would not. He needed to set that up, and that we would set it up per his son's schedule, so that there would be a clear communication of what we were doing here and what we were proposing, and the whole,
that's
situation.
why I was sort of angling so we could finish with a case study. Very, very nice getting you on the program with us, and we hope to see you again one of these days.
Well, thank you, Mike.
And Doc, it's interesting, and I think that just shows another light on what's going on down there. What we want people to do is go to VeinClinicsOfHawaii.com and meet Rebecca and meet the others, right?
Absolutely.
And we'll be back next time. In the meantime, just go and look at it. I'm not going to give you the phone number. You're going to have to look that up on the website. But go to VeinClinicsOfHawaii.com and check out. We'll see you next time.
Well, that's our program for today, and we certainly hope you enjoyed meeting us. Please come back next week for our next episode. And in the meanwhile, to learn more, please visit our interactive website, VeinClinicsOfHawaii.com. That's VeinClinicsOfHawaii.com.